Hey everyone, I hope you're all doing super well. Welcome back to Karan Academy. My name is Karan, and today we're going to be talking about pneumothoraces as we near the end of this respiratory series. So pneumothoraces or a pneumothorax is a very common clinical question, comes up very, very commonly, and it's one that you probably have encountered in your preclinical years. Today, I hope to add a bit of clinical context to what you probably already know, so you can have a more holistic and systemic approach to these kind of presentations. So as the name suggests, pneumo meaning air, thorax, well, your thoracic cavity, and refers to air being abnormally present within the thoracic cavity. Now, this usually happens or can be because of a few reasons. Firstly, it can be spontaneous, meaning it happens without any sudden trigger that we can identify. It doesn't mean it doesn't have a cause. It can be either primary, which is just a primary spontaneous pneumothorax, means the person had no risk factors and developed this pneumothorax. And secondary would mean that they have an underlying pathology that has put them at a higher risk of developing the pneumothorax. These include things like COPD, lung cancer, pneumonia, and emphysema as well. And we'll talk about why that's a risk factor in a second. And the second type would obviously be a traumatic pneumothorax. Now, this can often be penetrating injuries, high-speed motor vehicle accidents, and so on. So risk factors, modifiable risk factors, as you might have guessed, smoking is a risk factor for pretty much every respiratory condition under the sun. Trauma, as you can imagine, as well as infections. Now, infections is an interesting one. So you ask yourself, well, why do infections lead or put you at a high risk of that? We'll talk about that as well. And then non-modifiable, old age, severe asthma, COPD, as well as Marfan syndrome. So let's break it down into what's happening, and then we'll go back to these risk factors and talk about why each one of them is a risk factor on a kind of a microscopic level. So going back to our basics, pneumothorax is air in the pleural space, right? Now that air can either come from two places, from the outside in or from the inside out. So if you have damage to the parietal pleura or a break in the parietal pleura with air entering from the outside environment into the pleural space, that's one way. Or you have damage to the lung and the visceral pleura from inside, and then you have air leaking from the alveoli into the pleural space. That's the second type. Now let's go back to each one of the causes we've talked about, because I like to explain things, so hopefully everything makes sense. Obviously, trauma, let's start with a simple one. So trauma, pretty straightforward. If you stab someone, you are going to break their or damage their visceral, their parietal pleura. That's going to leak air in. Then moving on to something like emphysema. So why do people with emphysema or COPD have a higher risk of pneumothoraces? As you know, with emphysema, we have destruction of the nice alveolar air spaces, which become expanded and balloon up. Now, obviously, the membrane of these balloons, or the alveolar membranes, are going to be very weak at this point. They're going to be very poor at diffusion, and they're also going to be very susceptible to breaks because of the structural loss of structural integrity. These emphysematous bullae are very likely to rupture, and when they rupture, they are going to take, if they're on the periphery, they're going to take some of that visceral pleura with them and rupture and leak air into the pleural space. That's COPD. Lung cancer and pneumonia, with both of them, we have inflammation and a lot of it going on at the alveolar level. This again can lead to damages in the visceral pleura. Additionally, a lot of these conditions, considering how inflammatory they are, you're going to have a replacement of your alveolar membranes with fibrous material. This fibrous material is not going to be as strong, it's not going to be as elastic, and therefore, as you take nice deep breaths in, it's going to be kind of pulling on a plastic cling wrap, which is very easy to tear, versus a nice elastic balloon-like material, which would expand and contract. So which is why lung cancer and pneumonia both can cause pneumothoraces. Age, as you can imagine, the integrity of the alveolar membrane is going to drop with age. Makes sense. Asthma now is an interesting one, because in my head, asthma is at the level of the bronchi, right? Why do we have an issue in the lungs themselves? Well, what's happening with asthma is over time, you get something called lung hyperinflation if it's severe asthma. Well, it's because you're not getting enough air in. As you try to puff in huge deep breaths, your diaphragm is still going down, right? But there's not enough air entering to the bronchi. So imagine you have the lung basically closed up at the level of the bronchi, but you're still pulling down on the diaphragm. That negative pressure, and a lot of it, is going to be like ripping through the alveoli on a structural level. It's almost as if you fill a balloon up partly and then you start pulling on it further. Yes, it will hyperexpand to a certain degree, but it's going to be very likely to rupture. And then Marfan's is the last one. It's a good association to know. This is your typical tall basketball player. The reason people with Marfan's get pneumothoraces is not because of their height themselves. So the height, the high arched palate, the aortic issues, all those are independent, but the root issue is that of a connective tissue disorder. Now, with the connective tissue disorder, obviously, one of the connective tissues is going to be your alveolar membranes. And if you have inflammation or replacement of that good elastic tissue with fibrous tissue, again, same thing is going to happen. It's not going to expand well. And if you try expanding it too much, it's going to rupture. I know I went on about that for a while, but hopefully that makes sense. So I've already talked about how that can happen, but it's important to know the differences between the two types of pneumothoraces. Well, we broadly have tension pneumothoraces and non-tension pneumothoraces. Now, what is a tension pneumothorax? Now, a tension pneumothorax is a situation that we create. This is a situation where we end up with a one-way valve. Now, what is a one-way valve and when can you get that? Good question. So what quite commonly happens, especially with traumatic injuries, so damages to the parietal pleura, what happens is that the flap between your skin and the subcutaneous tissue and the visceral and the parietal pleura kind of acts as a valve. So every time you take a deep breath in, there's going to be negative pressure in your thoracic cage, which means air is going to flood in. But as it floods in, the actual structure or the wound on the structural level is going to be in such a way that it's the flaps are not going to allow air to leave. And that's going to cause a situation where you have air that's coming into the thoracic cavity but can't leave. Over time, you're going to have a pressure buildup, right? More air equals more pressure. And with time, you're going to have immense pressure in that part, as you can see here. And what that's going to do, it's going to start compressing on nearby structures and would cause something called a shift or a contralateral shift to the, or contralateral just meaning shift to the other side. Now, that doesn't mean that all external traumatic injuries are going to result in a tension pneumothorax. If you have a simple in and out, that like this would act as a two-directional valve. So every time you take a breath in, air is going to come in. Every time you take a breath out, some of that's going to go out. You're still going to have air in because you've lost that negative tension of the parietal pleura, but it's not going to be as bad as a tension pneumothorax. The other reason why a tension pneumothorax is really bad is because, as you know, in order to breathe, you need to create that negative pressure in your thorax, right? Because that's what's going to be sucking in air from the outside environment. With the tension pneumothorax, you effectively lose that negative pressure, right? Because we have so much air that negative pressure is now positive pressure. So in addition to all the compressive symptoms, which can lead to hemodynamic compromise, and it's what we look for with tension pneumothoraces, we also will have a lot of difficulty breathing, at least in that particular lung. So some signs you need to look for tension pneumothorax, and I've indicated whether this is a clinical sign or an X-ray sign. So hemodynamic compromise, you would check their vitals first, and you would assess their hemodynamic status that way. You would look for tracheal deviation, which you can do clinically by using your index finger, middle finger, and your ring finger, just running it down the trachea, tracking it, and seeing if it deviates one way or the other. Hyperinflation of the contralateral lung. You can assess this clinically by either measuring the degree of inflation, or you can also check for that on a chest X-ray, where you would very clearly see a discrepancy between the lung sizes. You can also have depression of the contralateral diaphragm. Now, the reason this happens is and then this would obviously be a sign that you can see purely on a X-ray. As you're pushing everything onto the other side, it's gonna, as you can imagine, move wherever it can, which means that the diaphragm is going to move down and you can have a depression of the contralateral diaphragm. And the heart position as well. You can assess this clinically by assessing for the apex beat and heart sounds, but it's going to be clearly seen or much better seen on a chest X-ray, where you can look at the heart borders more distinctly. And here we have two images. It might be a bit hard to assess at your level, but if you see here, we have the trachea, and we can see its bifurcation into two. Similarly here, what I would like you to do is to assess the trachea as it's going down and seeing if it's bending one way or the other. Now, to note, most tracheas are slightly deviated to the left to begin with, but that's not what we're looking for. We're looking for a trend. We're looking for a bend, right? So if this is, as you can see, slightly to the left, it's not as big of a concern as this one, which you can see is clearly pushed to the left side. You can also try assessing for hard borders. And as you can see a slight bit of the hard border here on the right side. Here, it's completely distorted and it's probably pushed a bit to the left. If you can also look for the actual lung markings, you can see that they only extend up till here, which is where the arrows are. So we have 1 arrow, 2, 3. So the lung, which is collapsed, it is practically here, right? And this all is air, versus this lung where you can see that it's clearly lung markings are extending all the way out to the periphery. Here too, we have a collapsed lung. Sorry. As you can see, all this part is completely blacked out with no lung markings, and the lung is pretty much here, but we don't have as much of a compressive picture. Before we move on to treatment, the other thing I want to talk to you a bit about is the difference between pneumothoraces and atelectasis. Now, this is one topic that really I struggled with through pre-clin and didn't really understand much of it. Over time, I think I have a better understanding now. So the primary differences with atelectasis, you have basically lost that nice alveolar, grape-like, sponge-like structure of the lung, and it's now just squished, but there is no air in the pleural space, versus a pneumothorax where you actually have air in the pleural space. The way I like to think about it is atelectasis commonly after surgery, and that's often due to decreased respiratory effort. The way I like to think of it is if you have your kitchen sponge you used to clean stuff with, if you just compress it slightly, that is what atelectasis basically is. You have compression of the alveoli, and obviously you can't breathe as much, and that too can constitute or is sometimes called a collapsed lung, but it's not quite the same. Similarly, however, a pneumothorax, you're going to have actual air in the pleural space that's compressing the lung from outside, versus atelectasis, lung is collapsed on itself. Hope that helps. How do we treat it? So here's a stepwise kind of a really basic approach to pneumothoraces. So the first thing you're going to do is doctor's ABCD. So this is going to be your kind of first aid. You're going to make sure that the airways are okay, they're breathing well, circulation, all that is fine. You want to make sure they're hemodynamically stable. That's the first thing you have to do, regardless of anything else. Step 2 is assess clinical severity as well as the size of the pneumothorax. How big is it? So if we assess the size, we have to assess how big is the pneumothorax. So if it's small, that's usually less than 2 centimeters. Moderate and large tend to be greater than 2. If it is a tension, regardless of size, they need immediate needle decompression because they have air trapped that's causing a buildup of pressure, and that's going to be really bad. For needle decompression, we go for the second intercostal space, mid-clavicular line, and that's usually with a 14-gauge needle. And that's to basically let out some of the air. And then we can obviously, we would close it up with a dressing because we don't want to leave an open hole because that's going to lead to the same issue again. If it's a small non-tension pneumothorax, which are going to be the bulk of your spontaneous primaries, and if they're clinically well, you don't have to intervene aggressively at this point. Actually, there was a study done at Monash Health which found that conservative strategies to small non-tension pneumothoraces actually led to better outcomes than using chest drains. And chest drains, obviously being an invasive procedure, are going to have their risk of complications, further pneumothoraces, infections, and so forth. So we manage them conservatively with high flow oxygen if they are hypoxic, and pain relief because it's going to be painful. If they're unstable and you have a large pneumothorax, you can try to aspirate the air and apply a dressing. If that doesn't work or if they're still leaking, you can put a chest tube or chest drain in the fifth intercostal space anterior axillary line. And then you check if it's still leaking after a day or two. And you use a device that is based on water, and you basically assess for bubbling. And that's your go-to indicator of whether the pneumothorax is still leaking air out. If it's still leaking at that point and nothing else has worked, you might consider VATS, which is a video-assisted thoracoscopy, where you might actually go in and try to fix up a bleb if that is the cause, or try to surgically close up the site that's leaking air. And then you can also do a pleurodesis, which is, again, sticking the pleura together to prevent that further leak from happening. I hope that all helped. That's all the information I had today on pneumothoraces. As always, if you have any questions, feel free to get in touch on my email or contact me on Facebook. I'm always more than happy to help. And yeah, as always, please look after yourself and please look after your loved ones.